So I give this title of osteoporotic hip fractures because today's era it is being combined as a common injury in the elderly. So we are assuming that we are treating the elderly, and what I have tried to highlight in my first slide is that prevention is the key actually. Falls in the elderly has to be understood and kept in the mind of the caregivers, and how to reduce the fall risk should be a priority in the preventive healthcare. So my first slide is to sort of make everyone aware and make them awake to this fact that if we prevent this injury, I think a big problem is being solved. So in my talk, I would be touching upon the fracture by the surgical care, but majorly I would be talking about the holistic care which is required in such patients. So as hip fractures or proximal femoral fractures were actually meaning fracture neck of femur and intertrochanteric fractures. And if we consider the fracture neck of femur in the osteoporotic elderly, probably the answer to it is to replace. And if you look at the intertrochanteric fracture in the elderly, I think the standard answer and the standard of care is stabilizing them. So what's common to the whole scenario? The common thing is that we need to get them up and about. And I think the clarity about the surgery has to be the treatment is a standard of care now. So the thing which has to be clear at the end of the surgery is that the fracture scenario, the lower limb needs to be stable. Whether it's a replacement or a fixation, we have to provide a full weight bearing to the elderly from day one. So that's the goal of surgery. And let me take you towards the holistic care. Now, we've already talked about the burden of disease. This is the latest data from the website from the Global Burden of Disease. And you can see as longevity is increasing over the globe, the fracture numbers are going to be increasing and they are touching millions. So it's a huge problem. And let me take you to a few facts which are the burning points on the holistic care of proximal femoral fracture. The most important probably is the bone density, the osteoporosis. These are the patients where we need to address the bone density, both for giving the appropriate surgical care, for healing the fracture, and the most very important thing, to prevent the second fracture happening, and indirectly adding longevity to the patient. So periodic evaluation reinforces the need for continued treatment for both the patient and the physician. Calcium and vitamin D. Vitamin D treatment alone is not beneficial, but when combined with calcium, it significantly lowers the risk of fragility fractures. Low dose of vitamin D does not enhance fracture healing, and high dose of vitamin D was significantly detrimental. So the most talked about treatment for proximal femoral fractures after the surgery has been done is bisphosphonates. And bisphosphonate therapy can be commenced early after fracture if clinically indicated, and the early is still not clear. I think the ideal is at stitch removal. Denosumab is the next important drug which has helped us in treating these osteoporotic fractures, but the new concern which has come is rebound fractures. Meaning if a dose is missed by the patient or he discontinues treatment and doesn't add another treatment for osteoporosis, the probability of getting a vertebral fracture is up to 10%. Teriparatide, hip fractures indicated for osteoporosis treatment, are potential candidates. Its usefulness as an adjuvant treatment for acute fracture healing is less clear and unsubstantiated. Romosumab is a reserved drug, and it cannot aid in union, but it can be a second drug to patients who don't tolerate or who are getting into a holiday from bisphosphonates. However, there is a caution raised that the patients have to be screened very well for stroke and cardiac events. The next part is the timing of surgery. There is huge data available now that within 48 hours is the ideal timing, and this is what is one of the major factor which helps upon giving longevity and decreasing the mortality of the first year after a hip fracture. There's a very important and a large hip attack trial which had been done, which looked into comparing less than 6 hours and less than 48 hours, and they really found that there were no difference in mortality. So we really don't have to rush within 6 hours, but then within 48 hours is probably the global policy which is being aimed at, but globally people are struggling to achieve it. And I can tell you the scenario would be even more challenging in the developing world. So the fact of the 48-hour theory has been tested in various publications, and it has shown that it does have a role in decreasing mortality. So cumulative first year mortality after such fracture varies between 20 to 40%. Higher rates of mortality in men and older patients. Very high immediate after fracture, hip fracture, rapidly drops over the first year. And these numbers are actually stabilizing over the last 1 decade or having a slight downward trends in certain countries. And there are various papers which come out with this data that when there are patients with combined comorbidities, the possibility of mortality in the first year is higher. And as talked earlier, two different 75-year-olds might not be the same. So the fact about the frailty index, the patients who are underweight, the patients who are physically inactive need to be taken care of better because the mortality has been seen to be more in them. Certain non-pharmacological interventions: maintain adequate protein intake, maintain adequate serum levels of calcium, vitamin D, try to include some amount of exercise into their daily activities, and identification and treatment of all risk factors is mandatory. This is very interesting. Limit the consumption of coffee and alcohol, not more than 4 cups of coffee and not 2 units of alcohol, and cessation of smoking. There's a lot of literature on this. So let's move on to the next thing, the most important thing to sort of evaluate osteoporosis in the population, and DEXA is one of the most important investigation. It has been recommended for screening osteoporosis in elderly female and recommended over 65. And there is an association of monitoring and occurrence of risk factor, hip fractures, and occurrence of the second fractures. So BMD monitoring in routine clinical practice setting was associated with a reduction in fracture risk in women undergoing BMD monitoring because they were aware. Medication use was consistently greater in women with BMD monitoring, and treatment switching was more likely, especially when BMD monitoring detected a significant decrease in BMD. So both the patient and the physician became more aware and conscious about the problem they were dealing with. So BMD, DEXA scanning did have a good role in preventing the second fractures and increasing the longevity. The last thing which I would address in this talk is anticoagulants. So if you ask me, the 3 common things which delay the hip fracture surgery is non-availability of the operating room, multiple comorbidities, and blood thinners. All these old osteoporotic patients are on blood thinners. So there used to be a controversy on what to do about them, when to stop them, how much to stop. So there are now a lot of evidence and guidelines by the anesthetist and the critical care physicians that any single anticoagulant medication is not a contraindication for spinal anesthesia. And the perioperative antithrombotic therapy and the risk of blood transfusion is not actually there. So this is one of the latest guidelines by the anesthetist, and it says that it gives you a good chart on what can be done when they are on thinners. But it also says that in the case of a significant operative risk, the treating team should follow an agreed hospital management policy. So we need to have in-house policies. And to end, I think we need to start having registries for hip fractures, especially the osteoporotic ones. We have the Asia Pacific Fragility Fracture Alliance, and Indian Orthopedic also Association is also initiating a hip fracture registry, which will actually tell us the magnitude of the problem and help us, introspect and try to address this problem. So it's going to be a team effort to handle the osteoporotic proximal femoral fracture, and delaying frailty is important. The importance of acting aging is very important. So thanks a lot for your attention.